mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The point-of-care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point-of-care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point-of-care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Okay, and good afternoon, everyone, and welcome to PerfWeb 32, Day 1. Today's program, of course, I'd like to thank our sponsors, LivaNova and Siemens Diagnostics, for their generous support of our program, so thank you very much. Before I get started with the introductions, I'd like to ask all of you out there to do us a huge favor. If you're watching us on YouTube, Facebook, I'm going to say it right this time, Twitter or LinkedIn, please, you like that?
Yes.
Please do one of the following. Like us, share us, follow us, or make a comment. In fact, and make a comment if you don't mind. Also, for you YouTubers out there, please give us that thumbs up and make sure you click that subscribe button. It's very important to us. We are continuing to gain ground on the subscribership, and I'd really like to get it up even more. So whether you're watching this live or you're watching this later, hit that subscribe button for me, please. If you'd like to be a part of our program as a presenter and join our robust resident faculty list, please send us an email at contact@perfusioneducation.com, and you see it right down there. Send us an email, let us know a little about you, and tell us what topics you'd like to lecture on, what your area of expertise is, maybe your bio, or just reach out to me by telephone and ask me what I think. We're always looking to increase our faculty list, but you can see on our website here, Perfusion Education, if you want to scroll through that, David, you can get a feel for all of the people that we have on this list. Oh, a nicer picture of Stephanie, I see. Just go ahead and scroll all the way down through to the bottom. But you can see our list, our faculty list continues to grow, and would really like to add you to this. Now, usually I do Slido, but today we're not going to do it, just for the sake of my not getting it prepared. But we are going to use it on Saturday. So on Saturday, I am going to be using that online polling software since we have it. I'm just not using it today. When you see this animation, the phone lines are open, and that means you can call in and be live on the air. Now, go ahead and open the phone lines now, and let's just leave them open from the very beginning. Okay? Now, let's get on with the introductions. You all know me, Joe Basha, your host. Of course, you know Tammy Sparacino. She's been here many, many, many times. There she is. There's Tammy. And next to Tammy is Mike Brown. You know Mike Brown. Both of these are seasoned perfusionists, both graduated from Texas Heart Institute, both work here in the Houston area. And they have, I think, some really interesting perspectives on what our topic is today, which is, where is our profession going? What is the current state of perfusion, and where is this profession going to? So let's start off with a couple of knowns. We know that we have 4,300 plus or minus perfusionists in the United States, North America, okay? I think it includes Canada. So we're a very small fraternity. And I know that over the course of the past 41 years, for me anyway, I have seen this profession both evolve and also devolve to some degree for various different reasons that I hold those opinions. But, you know, I'm one person with one opinion. You are coming at this from a completely different paradigm and perspective. You're coming at it from a different paradigm and perspective. Things are different now. You're younger. Well, I think you and I are contemporary in age. I might be a little older than you, but you're clearly younger. And there's people that are also much younger than us, and you probably have more exposure to them than I do. But the millennial attitude, the millennial thought processes, more people getting into this that want a greater degree of work-life balance, pay, benefits, managing, raising a family, starting a family for that matter. All of those things, you know, I don't feel like I had those challenges. Even though they may have existed, the philosophy of the profession at the time was such that it just didn't matter. We didn't think about it. You missed Christmas, you missed Christmas. You missed the birthdays, you missed the birthdays. It just was what it was. Mm-hmm. So understanding where I'm coming from in terms of this program topic of what is the state of our profession as we see it, and then where do you see this going in the next 10, 15, 20 years, maybe even beyond that, for all of these young folks that are coming out of training. How are they going to be able to have the same careers that we have really enjoyed? At least it's been fun for me. Not always fun, but overall fun. So we could just, I think, let's start from the end and work our way back if we can. Mike?
Yeah, I think right now, I believe if you look at models of how many perfusionists we have out there for the need, it looks like we've reached that little bit of a cycle. We've talked about this a lot, how there are certain times that there is a glut of perfusionists, and other times there is a level that we just can't find enough people to fill the positions. And I think that's kind of where we're moving right now. Mm-hmm. People ask me, we get a lot of students that come in and watch us do cases and with ECMO and stuff.
What kind of students?
Some students that are coming that are thinking about going to perfusion as their career.
So college level students.
College level
undergrad.
Students. Right, right. Mm-hmm. And they ask, you know, what does the future hold? And I keep telling them I believe it's bright. I believe that we have a very unique profession that tends to retain those people for a longer period of time than a lot of other professions do. Mm-hmm. Most of my contemporaries, I look back in the AMSEC booklet of an American Board booklet, and I think every one of my classmates that I graduated with are still working. And so I think that bodes very well for our profession. The fact now that we need more there, I keep telling the students, now's the time. If you want to go into perfusion, do it, because I think the need is there for the next, I would say, 4 or 5 years. And of course, as the older folks like myself are starting to get out of it, those positions will open. New challenges with the ECMO, with blood conservation. Perfusion has always been kind of a catch-all career, in that if there's something to be done, the perfusionist will probably end up getting involved in it, because we can do a lot of different things. So I think at this particular point, it looks very bright, and at least I would say for the next 10 years. Beyond that, maybe we'll hit that glut again, but I encourage people, if they want to consider perfusion as a career, to go for it. It's interesting. Will keep you going. You'll always have a good job with a good salary, and I'm very pro perfusion. The little small things that detract, I think that we're getting past that. We're able to have more willingness to be able to work with our surgeons and get time off and be off when they're off. And so I think some of those old pressures that you and I used to be, because we were the only ones around, are falling by the wayside because we have more perfusionists in the fold now that can handle the workload. So I think that is, the quality of life has gotten better because of that also. So bright future. 20 years may be a different situation though.
I agree with that. Mrs. Sparacino?
Well, I agree with everything that you said. I think right now, what's interesting is the people that are already committed to perfusion, have gone to school, who are getting jobs now. They, because of the nature of the market and that we have, you know, a lack of perfusionists, so jobs are plentiful and lots of choices are available. I think the ones that are coming out now have a lot of power over the kind of job that they want. Do they want to work a lot? Do they want to be at a busy place? Whereas when I graduated, you just took whatever job was available that would, you know, meet your very minimum standards. You know, my minimum standard was I wanted to stay in Houston. That was it. Beyond that, as long as I got a job, it was good. I don't think it's that way for them right now. They're in a very fortunate position.
Yes, they are.
They can pretty much pick where they want to go, pick the kind of practice that they want to be in. And I think you're right. I think it's going to be that way for at least another 5 years because it's going to take a while to get more people. Are the schools going to start training more people? Do we have enough cases to do those sorts of things? So that's going to kind of be the challenge.
Those are all very, I think all those are correct. You know, when I started, it was very similar to where it is today. When I first graduated from perfusion school, there were a lot of job opportunities. And so I watched that over time become less and less and less and less and less. And what happened, I don't know if you all, I think you might remember this. You've been 20 years?
17.
17 years. So you might not remember this, but you may. But there was a time when there were so few perfusionists and there was a big argument about who could train perfusionists. And the surgeons got together, and I forgot the guy's name now, but there was a big fight between surgeons and the American board, a lot of other things like that. And they actually, that's how Barry University and Perfusion or Psych or Perfusion Services Inc. originally started their training program.
Right.
And they were taking people, okay, and I remember this very well. This is a true story. I was a chief at the University of Pennsylvania, Hospital of the University of Pennsylvania in Philadelphia. And they told me that a new guy was starting on Monday. And the guy had graduated from their perfusion school that they originally opened at Barry University. Now, things with Barry University probably have changed quite a bit from then. We're talking a lot of years ago, probably I guess it was 1983-ish, somewhere around there. And so I met him in the lobby and was taking him upstairs. And so I said, so, tell me about yourself. What did you do before you went to this, I think, 1 year perfusion training school? Right. Hardly did any cases at all. He was a truck driver. I was like, what? You were what? He had no medical, he was completely ill prepared to do this job. So what the surgeons did, the ones that were involved in this, at the time, thinking that they were solving a problem, created an even bigger problem by lowering the standards of the people. But that was the start of the pendulum movement from not enough perfusionists to this major glut of perfusionists. There was a period of time I remember perfusionists couldn't even find a job. They couldn't even work for free. But now I've seen the pendulum all these years going on swung all the way back to the other direction, and now everybody is strained. Now, my opinion is we're kind of moving a little bit further back towards the center. I'm starting to see some stabilization in it, but it's really not where it needs to be. Now, there's pluses and minuses to that. If you're an institution or you're a private service providing company, that's not good where we are. If you're a clinician who works for an institution or a private service provider, then it's a great place to be.
Right.
But, you know, everything does seem to always find its balance at some point. But we're not the only ones. Heart surgeons. There's a tremendous, recognized crisis shortage of qualified cardiac surgeons. In fact, we all know that they have dusted they have brushed the dust off of people who shouldn't even be operating anymore and brought them back, and we've seen that too.
Yes.
So I think nursing, we have a nurse in our audience. Nursing is experiencing, I guess it's the type of nurses maybe. I think not necessarily a nursing shortage as a whole, but critical care trained nursing is definitely, because we're seeing, how many times have we seen a 2-year nurse or just graduate nurse in the ICU being proctored with 1 year experience, or not even a year, just graduated, and the only experience they have is there. Is that really where you learn your fundamentals of what your job is going to be? So those are my thoughts on it. So you want to add to that?
Yeah, the nursing profession, which my wife is a nurse and my niece is in nursing school.
Congratulations.
They are pushing so hard because of the supply is so much less than the demand. And they've started out as nurses used to be in 4-year degrees, get their Bachelor of Science. There was much more of a push over the last 10, 15 years of moving toward AD programs.
Yes.
And now, from even there, I heard advertised on the radio the other day, sign up, become a nurse in 6 months.
Diploma program.
Diploma programs,
Yep.
right.
Yep.
And it was the same way kind of with perfusion. When I started and went through school, in my institution, we put out 40 perfusionists a year.
Right.
Because that's what the demand was at that time. Cardiovascular surgery was booming all over the country, and that is what was required. I think at this point now, with the lack of CV surgeons, and our perfusionists starting to swing back a little bit more, that those numbers will balance themselves out, and what we're going to continue to do is to get very highly qualified people entering into perfusion school, which I'm extremely excited about.
Well, I think the compensation and the lifestyle is there to attract a higher level, you know, of a higher quality of person wanting to do this profession.
Right, I'm with you. One of my classmates, we started with a class of 20. One person, for some reason, could not come into the school. I think there were some personal things.
That was probably me. No,
one of the perfusionist students was a police officer. No medical background. The person did not make it through. A couple of more of them were people that really did not have the medical acumen behind them to really grasp it and go. And out of that class of 20, we graduated 11.
Well, let me ask you a question.
Yeah.
What were were there established prereqs?
There really weren't, obviously, because one of the guys who got in was a police officer. He did not have these things. There was, you could tell, a desire to try to bring into the school those people that had some type of medical degree, whether it be EMT, nursing, respiratory therapists, anything along that line. But there just weren't that many people that knew what a perfusionist was when I went through school 38 years ago to know exactly what it was. And but I think what we're seeing now. I mean, we talked about the millennial situation in previous PerfWeb series, but I really see that the students that come in now have a wealth of medical background.
Oh yeah.
And they are, which is needed to be, because our jobs, Joe, as you well know, I mean, we were no longer just running the pump. We did the life support teams, balloons, transplants when they first started, and cell salvage, which was a huge, and has always continued to this day to be a huge portion of our private contract business. And
it is huge.
Just what you need to know and to be a perfusionist now is much, much more demanding than what it used to be when we got out. Did we learn it? Oh yeah, we learned it in time. I never ran a cell saver in my perfusion career because it was not part of what this program allowed. As soon as the first day out there, I was running cell savers, and I learned it along the way. But these students, if you have the background, to us I said earlier, and I want to allude to, if you have that type of medical background and perfusion sounds like an exciting thing for you to go into, now's the time to do it.
I think that's a very good point. And I want to talk to you a little bit about, and as a side note, if you don't mind, I just have to say it. When I started in this industry, cell savers were not commercially available. So that's, it was a complete, and that's, I think, what I was trying to say earlier, is we went from what were very high standards to get in. Because they would take people coming out of the military, they would be working in the hospital in a different department, but the surgeons would kind of identify them as, I need you to run, we need to train you to do this. And that's kind of how the training was done. But they took people that they knew had a background that they can get this. I just need to show them how to do this. But everyone was motivated to learn. They were self-teach themselves. That's really what you had to do back then. They didn't have internet. They didn't have courses. There was no such thing as a conference or a meeting. It just didn't exist. And so, that's the way it was. But let me ask you, now today we have, he was just talking about nursing. Nursing, another thing, used to be just a quick diploma. Then they had associates. Then they went to bachelor's. Then they went to master's. Then they went to PhDs and nurse practitioner, advanced practice. So that too has been an evolution. But we're seeing that go from what was at one time a diploma with 6 months of training, and you're a nurse. And those are probably the best nurses you could find, because they had to learn everything on their own when they got out, and they really understand stuff. But you saw it go to a much more formal, much more lengthy, much more difficult education. And now you're telling me that they're going right back full circle
sliding down
to,
the slide.
in order to fill the roles, we need to do this and almost make it a trade versus making it keeping it as a profession. I think that's flawed. I think that's wrong. I don't agree with that. That's wrong.
It's just what you described happened when you had a shortage during your early part of your career. You were just worried about turning out bodies to be able to fill jobs. And we're not in the kind of field that's something that we need to do, no matter if you're a nurse or a perfusionist or a retired surgeon coming back from, quiet life. This is a highly...
To wreak havoc upon us?
We need to have people who are highly qualified, motivated, and educated.
Well, let's talk about that motivation and education and all of that kind of thing. So we have currently for perfusion, we still have, if you have your prereqs, so you have to have a bachelor's to get in, but then you have a diploma program after your bachelor's, you have a master's program after your bachelor's, you have PhD programs that exist in perfusion. Any of that necessary? Let me start with you.
Well, I don't think I think what I received was not a diploma, right? It was from Texas Heart. It was a certificate. So that's all I got post.
Well, it's a diploma. Certificate, diploma program, certificated program, same. I mean, it means the same thing to me.
Okay. So I feel like I learned all the basic things that I needed to know in that program. But I do think there's a disadvantage, because I think that when you get into the bigger institutions, working for hospitals, not necessarily, private staffing type companies, that sometimes you're going to be offered more opportunities if you have a program that was a master's program.
For management or
Yes.
for leadership roles and all of that kind of thing.
And what's interesting is you can have people who might be better at, managing people, leading people, but that's not necessarily taught in the master's program. So, but if that's something you're interested in, that's probably the program that, you need to pursue. Also depends on what stage of life you're in. The younger people might have more time to be out of work. They're right out of college. They have more time to just go ahead and do it as a master's program. People who are in a different stage of life might just need to do the shorter program because you're not working and you need to get out into the workforce and be working as quickly as possible.
Get through school, and start your family like you wanted to. Your wife held off maybe her career. She wants to do hers.
Right.
We don't have 8 years for you to do this,
Right.
because time is ticking. That
But I
is
think
certainly an issue.
I think the American board does a good job of making sure that people get the minimum amount of education that they need to be successful practitioners, So I think the different programs offer opportunities for different people and what they might be seeking in their career.
Yeah, I think, at least this is my opinion, even though the board does do a good job, I actually have a good relationship with the board. I think they're an important institution for us to have for our profession. But at the end of the day, whose responsibility is it? They can set guidelines, but whose responsibility is it to know as much as you possibly can know about what it is you do to be the most effective you can be? Because I don't think any of us, now you go into the big institutions and sometimes they're cookie cutter, and the surgeons, there's still some old school guys out there.
Right.
Give me enough bananas, I could teach a monkey to run that pump. We've all heard it. So that's kind of their philosophy too.
Right.
Just go on pump, don't talk to me. It doesn't matter what you do, just turn the knobs. And they in many ways trivialize what it is we do and the contribution that we have. And I think most people, especially if they're a really fast surgeon, and they're doing reasonably healthy patients, kind of get away with it a lot of times. But those guys are old dinosaurs and they're going away.
They're going away.
The surgeons that we work with now, the younger guys or even the middle-aged guys, they value us and our opinions
Right.
so very much and depend on us.
Well, they
so
expect you
much.
to know more than just running the pump.
A lot more.
It comes down to the
lot more.
clinician.
Right. So whose responsibility is it? Is it the board's responsibility to put these mechanisms in place to prove that you've gotten the education that you need and the continuing education
Well, I think
that
it's
you
the
need? Or
minimum
is it,
amount.
well, yes, but they have a mechanism in place. But whose responsibility is it ultimately to have the information?
The clinician.
The clinician, exactly. And I think that's where I'm trying to go with this, is are we seeing people with the same level of enthusiasm that want to learn? In other words, the younger people that you work with, and you probably have more exposure to it than I do, and you too. You've probably worked with several people over the recent 10 years that are younger than what I'm used to you guys. So I don't necessarily have that experience. A few, but not too many. What are you seeing with the younger people and their attitude towards becoming masters of their profession?
I think I've seen a mix, just like you'd see
Yeah,
in,
it is a real mix.
You have some that are highly motivated and they want to learn everything that they can learn because they find it interesting. They got into this profession for a reason. And you have some people who are in the profession who want to just come to work and do their job and go home. And I think it's probably that way in almost any profession.
Right. I think so.
You know, that doesn't mean that person maybe doesn't do their job very well, but they've reached what they want to do and they're not really interested in growing their knowledge past that, other than what's practical for what their particular practice is. Now, whether that's going to serve them well, as, you know, I think our scope of practice, if you will, the things that, you know, places are expecting us to know and do, I don't know if that's going to serve those people well. It's going to depend on their particular situation.
How much of being protected because there's such a shortage do people have now?
Yeah.
Yeah.
You know, do we accept something now, or someone's level of both knowledge, enthusiasm, and all the things that it takes to do, curiosity, that it takes for us to do this job? Have we had to adapt and learn to accept less because there's nobody else to fill their shoes?
Yes.
To some
You
extent.
think yes?
Yes.
What do you
To some
think?
extent, yeah. But this profession has
Say that
always,
3 times.
It's kind of
Yeah.
that's a tongue twister for
Perfusion
sure.
profession.
Has always been, the profession itself has been a limiter of the people within it.
Say that one more time.
The profession itself has been a limiter of the people who are in it and how long they stay. Based upon what we have to do and the requirements of our job, it weeds out people pretty quickly. If
This
the
is
people,
true.
If the people do
Yes, I see
not
what you're saying.
want to, I mean, I've known quite a few people that have gotten into perfusion, and it's like, oh, I just love this, I love this, and about 2 years later, you see them, and they're kind of like, it's tough, but I'm hanging in there, and about 2 years later, it's like, I can't handle this anymore. I've got to get out and do something different. So I think that's kind of a neat thing about our profession is it stays, it's really good people.
It self-regulates.
It kind of self-regulates itself.
Yeah.
Because if you're really not capable of doing this job well, you get eaten alive at
Right.
work.
Well,
That's right.
and it doesn't necessarily have to be someone who's dangerous or can't
Right.
handle the responsibilities. Sometimes people are do quite well at what they do, but they don't have any interest in expanding their knowledge, I guess is the point I'm trying to make.
And
They-
some people just can't communicate it. They're brilliant. They're really good at what they do. But because they can't verbalize it, because they're shy, they're perceived a certain way.
Right.
You know, because you know how some of these surgeons are,
Big
both men and women.
personalities.
You're right. It's a dog eat dog world in there. It's war. It's open warfare.
But I think the climate with the relationships that are being developed with surgeons and other advanced, practitioners with perfusion has gone in a positive direction. Like you said, some of the, ones who were trained in a certain way and had a certain mindset, they're fewer and fewer. They're older and older.
Yes,
and
agreed.
the newer ones are like most things, when someone's newer in a profession, they tend to be more excited about it, interested in new technology, new techniques,
Absolutely.
and they're more collaborative. And I wonder if that's just a sign of a particular, society kind of thing, or if they're actually being taught that when they come out, they really need to be collaborative with everyone in the room.
Yeah, that's a really good point you bring up. I think too. You bring up some very good points. I think too that you're finding surgeons now, and even cardiologists and even nephrologists, even though I think they have the worst hours, even worse than a cardiac surgeon, frankly. I really think they do. Their hours are horrible. But all of these high-level physicians in the past literally didn't know they had children. They had them, but they didn't even know they had them. They didn't know what they looked like. They couldn't recognize them. because all they did was work. There was nothing else to do but hearts, vascular, whatever it might have been. I think even that has changed for physicians. I think physicians now, surgeons, want a life, want to have time off, want to see their children grow up. And so I think it's changed.
There's been a shift.
Because I think we got to that point way before they did. We wanted to have some kind of existence. We didn't sign up for that. We signed up for this because, and we accepted, of course, you accept less money, you accept less power, you accept less, highfalutin status and all that kind of thing. You accept less of that there's a compromise. I want some lifestyle.
Right.
But when you're the top person, you're the captain of the ship, so to speak. It doesn't mean they're better than anybody. I don't believe in that. I think but somebody has to be in charge. It's their patient. They're the ones that are operating on them. Ultimate responsibility, all that stuff. And when your mindset is there's nothing more important than the next case, there's nothing more important than the next 10 cases, and you just want to drive, it bothers you that everybody else around you is like, no, I want to go home. I'm not happy with this. And so their mentality is, what's wrong with you? You're not committed. I used to see that. I mean, I'm imagining you saw it too.
Oh yeah, big time. And I can honestly say over the years that my hours have probably gone down because of that attitude. Surgeons they'll just say, hey, we can put this case off till tomorrow morning. What's my schedule like tomorrow?
Would have never done that 15 years ago.
Never.
Not 20, certainly.
Next.
Not a prayer.
It was like next.
Would have started an elective case at 2 o'clock in the morning.
That's right.
No problem.
Right. Yeah.
Now, there's still some people that will do that.
We still know a couple of those.
There's a couple out there that are still doing that, but they're actually nice people too.
Right.
They, as neurotic, as hard driven as they are, they actually have that individual I'm talking about still has a thread of humanitarianism associated with them. So it's kind of funny. He's okay with, just get another team in here, we'll be fine. But they'll just go and go and go and go. But in the old days, people expected everyone to do it. And I think I am seeing a big difference in the surgeons, physicians' mentality that, you know what, I have a life, I want a life, I respect the fact that you have a life and want a life. And the relationship is far more personal, where that relationship was never very personal. It was for years I went through this profession with the relationship with the surgeons being confrontational. It wasn't good.
There was never any time to develop a rapport with a surgeon outside of the operating room, because all your time was spent there, getting that first case done, getting the room turned over, setting up for the next one. And then at the end of the day, you were so ready to get out of there, and the surgeon would go to the sleep room in the ICU in case anything else happened bad during the night.
Yeah.
These days, though, the weird thing about it, I'm older than most of the surgeons that I work with.
Yeah. Me too, and I used to be the youngest person in the operating room. I miss those days.
I was the baby, and that's long gone now. And ironically, it seems that a lot of the patients that I do now are younger than I am.
Yeah, that too.
That's a sure telltale sign. But these guys, and I guess that's probably the reason why we have not as much CV docs as we need, because they're just not willing to put up with that type of old schedule like they used to.
Yeah, that's true too. And look at the reimbursement. Look at the payments. I remember, and I know what was higher than this, but what I know I can say accurately is that in 1979, 1980, 1981, 82, 83, 84, 85, a surgeon, those dollars, we're talking those dollars. And again, I know it was higher than this, but this is what I know for certain, we're getting $7,500. Now, I've heard $15,000 on some occasions, but I know it was $7,500 for sure. $7,500 per procedure, per 3-vessel coronary, in 1980, in 1980 dollars.
Yeah.
Medicare reimbursement for a 3-vessel cabbage today in the city of Houston is $1,800. In 2020 dollars. So think about how much of a difference that is.
Right.
And look at how many cases Cooley did. I mean, at the time the price was, the reimbursement was that, we were doing 700,000 cabbages a year.
Yeah.
When it dropped to 400,000, everybody thought that the world had come to an end. Now it's 180,000, maybe 160, 180, somewhere in that range.
With an aging population.
With,
Right.
well, you got to thank stents for that.
Right.
So I want to talk about some of the challenges. How are we doing on time? We've been going for how long? Can we take a? We've been going for 45 minutes. Why don't we take a little 5-minute break? Can we do that? And then when we come back, I want to talk a little bit about, since we've, I think beaten up the past pretty well. Let's talk about the future. Let's talk about new technologies. Let's talk about evolving ourselves, or not us, because I'm not gonna. There's only so far. I don't have that many years left. Okay, But with that said, how can we advise or guide our younger colleagues into securing their future in this profession, which I really love. 41 years of it. You have probably 38 years, almost 40. You have 17 now. You still have a long way to go. You have another 20 years to go. At least. No?
Yeah, I hope so.
I hope so too. You're the youngest one here.
I am the youngest one here.
Yes. So I think you have a long way to go. Okay, so when we come back, we're going to be talking about those things for the future, for the second half of all of this, and leave the past behind. We're done with the past. The past is gone. So the past is going to go by way of the advertisement as soon as you click the button.
Mixed cannulae, expanding performance standards. High performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Percival, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
The The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat because that's the process. This is just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.
Are these mine? No. Oh, there's mine.
Those are mine.
Okay, welcome back. Yes, thank you. Okay, I guess that finger, that was, you're
That
on.
was you're on.
You're on. You're on.
On air.
Okay, so let's talk about the future. One of the things that I'm very supportive of is new technologies. And you know that I've been very interested in the CRRT world, even though I don't really feel that has caught on with perfusion very much, because it's really not, I understand, a perfusion function. But many of the hospitals I go to, or used to go to more frequently, it was mixed. You had some nurses that really understood it, did it well, no problem. They were well trained. They maybe had experience with it elsewhere. But there's a lot of hospitals I go to where they don't understand it at all. In fact, there's a lot of physicians who really do not understand CVVH. I've said for years that the biggest problem with the technology or the therapeutic modality we know as CRRT, continuous renal replacement therapy, is that it's called continuous renal replacement therapy, because it seems to fall into the purview almost entirely with the renal guys. And I think those two are mixed. I think you have some who are very, that trained with it, understand it well, but there's a lot of them who, if it's not dialysis, this really doesn't work, because there's not a lot of good, strong evidence to support it. But a lot of that has to do with the lack of ability to do a real trial because of the ethics associated with it. The patient is hemodynamically unstable in acute renal failure, or has severe lactatemia, has massive fluid overload. They're on multiple pressors. Well, if you try to dialyze that patient, they're going to code. And so there's a lack, there's this unwillingness in some ways to accept that the lack of evidence has nothing to do with the fact that it really doesn't work. It has to do with the inability to actually conduct that study in an ethical fashion and not cause harm to patients. So there's always this argument that's going back and forth. I had this guy that I used to know. His name was Luis Juncos. Smart guy. We were pretty close for a while, then kind of lost touch with each other. But he was a nephrologist and an intensive care medicine doctor, double boarded, or professor of medicine, I think. He was real smart. He was a real smart guy. And his favorite saying to me about that was that absence of evidence is not evidence of absence. And I thought that was very profound. It stuck with me from the minute he said it. I've said that, I've repeated that several times under certain circumstances. But whether you're talking about CRRT or CVVH, whatever you want to call it, ECMO, the new iteration of VADs that are coming out, the angiovac procedure, but how many more? Those are the ones that I can think of off the top of my head. Therapeutic hypothermia. That's another one for patients with not hemorrhagic but embolic strokes. Why do we? When you look at therapeutic hypothermia, it takes a very long time to cool that patient down with these external pads. Now, I know there was that one crazy guy that had this swimming pool. They put a plastic shield under the patient, and then they would flood it with this water and basically almost submerge the patient in ice water and then drain it and then put fans on them, and there was water all over the place. It was somewhat what's the word you use? Medieval? Yeah, that would be the word I was looking for. But would there not be an easy way for us to do therapeutic hypothermia with very little anticoagulation with a Maherker catheter and let's say a small cardioplegia heat exchanger? But just thinking aloud and thinking about these ideas, you know, doing the microcirculation thing, trying to learn what the pump is doing. I'm really having a hard time getting people, my colleagues, professional perfusionists, interested to want to do that. You know, this ELSA meter, the recirculation thing, or oxygenator volume thing, you know, just all the little things that you can do to increase your, not only knowledge, improve patient outcomes and value to whomever your customer is, whether you're an institutional perfusionist working for a hospital, a group of surgeons, private perfusion company, doesn't really make any difference. It's bringing more value. So how do you suggest, that's my thought, those are my thoughts. What do you think? How do you suggest a young woman perfusionist coming out of training, who's 26 years old, maybe already in a relationship, wants to start a family, just graduated from perfusion school, and has to consider, how am I going to make this profession for me last another 20 or 30 years?
Well, I think this isn't a new thought, but you have to be willing to expand your practice, whatever is going to be useful to where you are. You know, like Mike touched on earlier, perfusion gets a lot of jobs that are kind of related to us and sometimes kind of not related, but just because we're there, we're usually highly trained individuals who can take on new tasks and, you know, are reliable. And so lots of things fall your way. I think you have to go into that with positive attitude about that, because anytime you're doing those sorts of things, that's going to add responsibility to your practice and be able to make your team and department more valuable. Now, I think there's a fine line with some of the administrative stuff sometimes when you're stuck in an institution that they're doing. I'm not talking about those things. But, you know, like we can look back, I don't know, 8 years ago or whatever, when PRP was first becoming a thing. And some people were all for it and some people were not. And I don't mean in if it works or not. That's beside the point. The point
Doing
is
it.
doing it. That is something that very much could fall within our scope of practice. We have a lot of knowledge of. We're certainly better trained than, say, you know, a sales representative that might be coming in and doing these sorts of things for that. Now, should you work together with those people and learn those products? Sure, but the actual clinician processing of the blood part should really fall to someone who is used to doing those sorts of things.
You bring up such a good point. I mean, I love this point that you brought up. It is horrifying to me that they were allowing sales representatives with zero experience in handling a patient's blood to handle patient's blood and create a product that was going to be put on
in them.
not just on a bone, that if you get a deep sternal wound infection, that is a very bad problem to have.
Right.
A deep sternal wound infection is horrible.
But your point is absolutely, that's a whole nother thing. But being open to that, at the institution I was at, we were very open to that. We didn't think this is going to add more work. It's beneath me. Or it's beneath me. You know, like I can't do self-salvage because it's beneath me. We thought, you know what, we have a surgeon that's interested in this. Let's send somebody to get trained on it, and let's learn how to do this, and let's provide a service that he wants. And you know what? That paid off in the end, because we, you know, did this, then that went away because, you know.
They took it off the formulary.
Yeah, so it was, the reimbursement was gone, so hospitals stopped offering it. But because of that relationship that we had built with this surgeon, he was there for us when we all of a sudden had a dip in our numbers, you know, because we were billing for all of those things, and all of a sudden we're not billing for those things. This wasn't even a cardiac surgeon. This is a surgeon that we would normally have, any sort of dealings with, but we did. We developed that relationship. We provided a good service for him. We treated it like it was just as important as a heart surgery, showing up to do, these PRPs and self-salvage and things. And in the end, it benefited us greatly.
Yes.
And we were well respected, in a completely different field than cardiothoracic surgery.
As a as a member of the global patient care system, I guess that's how I would put it. We're not perfusionists. They're not nurses.
Right.
They're not, anesthesia techs or scrub techs or whatever. Every single one of us is a patient care advocate.
That's right.
At the end of the day, that's what we do. We're here to take care of the patient. That's really why we're there. Now we get paid for it. Nobody can work for free. We just can't. It's not the system we have. Well, I'm not going to say it. I'm not going to say it. I swore I would not say it. I'm zipping it up. How about you, Mike? What do you think? How is a perfusionist going to survive another 20 years, 30 years if they're, just graduating, maybe within the first 5 years of being out on their own now? One of the things, like, how do you think they should, since there's jobs available right now that they can sort of have a little bit of, selection, they have a choice now. One of the things that's always bothered me, I want you to expand on this a little bit, is I'm seeing some perfusion departments in the bigger institutions going into nursing service. In other words, they're being absorbed by the nursing department.
Yeah.
And even though I love our nurse colleagues, audience over there, and I think we work very well together, and we both have shared goals, we're very different people. And so how would you suggest, and there's the doctor working for a doctor group model, there's working for a hospital, there's working for a private contract group, there's going out and being on your own. All of those things are possibilities. How do you think somebody needs to look at this in order for them to secure their future?
I think you need to decide between places that are going to give you the opportunity to grow if you don't know that particular treatment method. And I think that's the utmost situation. Like I said earlier in the first part of the meeting, we did not know cell salvage and those techniques until we got out of school. Well, you're going to learn a lot more. What you learn in school is nothing to what you're going to learn being out there in the real world. I think you keep your mind open to new technology. Do not be afraid of it. Embrace it. Look for those things too, I think, that will give you the opportunity for long-term employment is synonymous with a long-term support, such as the CRRT you were spoken of ECMO. ECMO is just proliferating all over the world. I didn't know as much. The most ECMO I've done in the last 10 years of my perfusion career. If you haven't embraced ECMO, you better, because it is generally, obviously, 24-hour-a-day commitment to monitor a patient on ECMO, but they tend to be days running into weeks, things along that line.
Oh, it's not uncommon to see patients on VV ECMO for, not for lung transplant. I mean, that's a different animal altogether, but you're talking about the acutely ill patient,
Acutely
ARDS,
ill patient,
from influenza or whatever other virus they may have that caused the problem, or aspiration or whatever, but for weeks and months. And they're surviving.
And even if you're not the clinical bedside technician handling those, your input and your involvement should be paramount. You're still, if we don't become the people that insert them, stabilize them, change out the circuits when need be, provide input as to how we can do things better. When are we ready to wean? How important is that? To know that knowledge and when it's time to wean. You better not wean on a patient that's not ready. You'll lose them. You'll set yourself back days, or you'll more than likely lose them. And there for termination, all those things can be jointly attributed to efforts between perfusionists and the nurses. Of course, there's not enough perfusionists to monitor ECMO 24 hours a day around the country. Doesn't mean you should not be involved.
I agree with that 100%. Agree. It's a team effort.
Team effort.
Yes, absolutely.
Everybody has to be involved.
Right.
And everybody has to be willing to listen to each other. We may see things differently,
Right.
but let's try to understand the other person's perspective and why, and disagree respectfully and find the information out, or find somebody that's going to be an independent, neutral arbiter to make the decision about which direction they want to go in the best interest of the patient. I think we have to be able to do that. It's not that we shouldn't have turf wars. I think turf wars are just a mistake. What do you think about work environment? In other words, how do you feel about institutional medicine, which is you work for a big university hospital, or you work for a hospital system, you work for an independent, you're just independent and contract yourself out, you work for a physician group? You know, do you see any advantages or disadvantages to any of those? I have a few thoughts about it, but I'm curious what your thoughts are.
I think advantages are there are a lot of different ways in which to be employed by all those different means. I think Tammy alluded to it in the first part of the program, that if you want to go home, just come in, do your cases, and go home, then an institutional setting is probably what you need to look at. If that fits your
A
needs,
specific kind of institution.
and that is absolutely fine.
This is true too.
That's absolutely fine.
But I've seen
Those
this-
roles need to be taken care of, and those are a lot of jobs that are out there are like that, and that is, if that's the type of perfusion career that you want, that's beautiful. You're still taking care of patients. It's still all you're taking care of patients, no matter what capacity. Should you want to expand, learn new things like that, then maybe you'd want to go with a group that is willing to export their knowledge to other hospitals or other surgeon base. We talked about PRP. We've expanded into that with not only plastic surgeons
Yes, that's right.
doing work, but also some orthopedic surgeons who are now injecting the PRP directly into the different ankles and knees and things like that. It's been going on in Europe. Eventually it's going to catch on here. And I tell you what, that would be a place to really go into. We could be going out to private machines. I did this 15 years ago. Took private machines out to different hospitals, ran it for the surgeon there, made the product for him. He injected it, made a lot of money, and he was real happy that we were there to do it. Those are things that you can do also. Don't be afraid to embrace a new technology. Learn as much as you can. You can expand it within your own institution, or you can expand it out in the private sector on the smaller hospitals. That'll keep you busy, and do not limit yourself to one thing. I think is the biggest thing. Be open. Yes, it's going to cost you a little more personal time, but what you can glean from it, what you can learn, and if you want to provide your stability, know a lot, offer a lot, do a lot.
I like this. It's very good. Offer a lot, learn
Know a lot,
do a lot.
do a lot.
I like
Well,
that.
I think you make a point there when you said it's going to take a little bit of your personal time. We're professionals, and our job doesn't always just end when you leave. It's your personal responsibility to, you didn't understand something that went on in a case today, or go look it up, go ask somebody, find out about it. I mean, that's the difference in someone who has a career and someone who has a job.
Bingo. Very good point.
Right.
And and I to touch on that institution comment that you made, I think too, depending on the kind of institution or the kind of group, or that particular situation is going to provide a completely different type of experience. You go to a really large institution that's maybe associated with the university, you might have a lot of research opportunities. Maybe
Right.
that's of interest to you. So that would be the kind of job you pursue. Or maybe you go somewhere where they also teach perfusion and that you're really good at that. So that, would be a good job for you. Maybe that's not your forte. You're more you think you could really lead a department, and you can, you're really good at this, doing these committees and meetings, and that's a different kind of institution, and there's lots of opportunity for
Right.
growth there. The important thing is choosing a job that you think is going to fit your needs, so then you will stay happy with your profession. You're happy with your career choice. You're more motivated to stay on top of the education, to fill roles in our different, governing bodies out there, to come speak at talks, to, do your CEUs, not as an obligation.
I like that. So you heard Tammy, what she just said. So call us up to get on our faculty. Thank you. I appreciate that plug. Okay, go ahead.
To not look
Forgive
at
me.
CEUs as an obligation that you just have to check the box.
Right.
Use it as a way to actually grow, to try to, learn something that you find interesting.
I agree with everything that both of you just said. When I got my pilot's license way back when, when they handed me my license, they said, this is a ticket to learn.
Right.
And I think the same thing
Yeah.
applies to us in medicine and perfusion, in medicine as a physician. It's called practicing, right? In nursing, I think we all have that same obligation. But can I be a little bit provocative, just for the sake of the discussion?
Not you.
Yeah, not me. Okay, I want to be a little provocative. So I liked what both of you said. Find your niche, whatever that may be. However, and with that said, what if your niche is to be in a place that does bread and butter cabbages, resting heart, most of the time, or beating heart, off pump and beating heart now and again, and you just want an 8 to 5 job or 7 to 3 job that you can go in, do your case, and be gone. Okay? So, and there's nothing wrong with that.
There's nothing wrong with
There's
that.
nothing wrong with that. However, and again, I just am saying this to be provocative. It's not necessarily that I feel this way. But do you think that some people may feel that that person is not fulfilling their true obligation of having taken a spot to be trained to do a job that requires ongoing experience and ongoing education and ongoing practice in order to be really good at what they're doing? Because the program that they go to within the next 10, 15, 20 years, certainly 20 years, is going to morph, and the types of cases they're going to get are going to change, and the risk of getting some off-the-wall case, because you can do bypass, which means you can get a type 1 dissection in the middle of the night from a traffic accident or a transection or something like that. I did one time, a lady that skied into a tree, and she transected her aorta. Only the adventitia was holding it together to keep it from rupturing. She should have died. And so we had to, fix that. And if you have no experience with that, because you've chosen this type of job and you're happy with it and you've done nothing else, are there people that would look at that person and consider them to be
A risk.
well, a risk, but I guess to being, I don't know the word I want to use, having failed in their obligation for their profession? So again, I'm just asking to be provocative. It's not that I necessarily feel this way.
Well, I have a question. You can't you have no control over the kind of cases that you're going to do. So you may choose a job and it fits you well, but the only cases you see are cabbages, and they're mostly off pump, and that's what you do. All you can do is have protocols and procedures and wet labs to try to keep your skills up for things that maybe you don't do. I mean, I came from a practice that was very busy. We didn't get a lot of, dissections.
Stuff.
We didn't. We did valves and we did cabbages, and we were
Pretty
great at them, and we
straightforward.
knew how to do ECMO, and but we'd have the occasional, you know, ascending or something. But we had procedures and protocols and diagrams and step by step. If this happens, you pull this bag and this has everything you need in it, and these are the things you need to say to the scrub, because they also don't have any experience.
And a diagram.
And a diagram.
And you've thought about it through you've thought about it. So I
Yeah.
think that's where I'm going with this.
Yeah.
So if you're in that environment, I think what I'm trying to get at here.
You still have a responsibility to know these things.
Yes,
Yes.
that's
Yes.
what
I
I'm
agree.
trying
Oh, yes.
to get at.
Absolutely.
Oh, yeah.
And I think that keeps some people from then looking at that person and saying, how did you not know what to do? Doesn't matter to me that you picked that job. That's ridiculous.
Well, you can't
because
pick-
you
you-
know there's some elitists. Okay, I mean
Yeah.
I'm not saying that there's a lot of them, but there are some elitists out there that talk to a person, go to a meeting or something like that, and they find out what their practice is, and they're like, oh, okay.
Well,
You
I
know.
mean, we have that even here
Oh, yeah.
because we're in the community hospitals and not the med center. There's some people who think we're less perfusion qualified. I mean, that's fine. They can think what they want. We do all kinds of fun things out here.
This is true. They don't, but I think there's a difference between that and working in Gatlinburg
Sure.
in a place that does 150 mostly off-pump cabbages a year.
Well, you have to have procedures and protocols in place.
And you have a responsibility. You have the responsibility
Well-
to make sure. You can't say, well, I never saw this before
Right.
and I don't know what to do or how to do this. It's not my fault. That's what I'm trying to get at
Yeah.
here. Whose fault is that? Is it the institution's fault for not making sure you knew how to do it? Is it the patient's fault for coming to your hospital? Is it the surgeon's fault for not making sure he or she or made sure they knew and you knew how to do it? Is it your fault for not keeping your skills up, even if you don't have those direct skills with simulation, education, reading, talking to people, going to meetings, doing online courses, whatever the case may be?
I think it's falls to two people. The individual person, the clinician,
And the patient? No.
not the patient, and the employer, whether it's an institution or a group. If you are going to have a perfusion department, you should have someone, it could be an administrator or it could be a perfusionist, who has thought about these things, put protocols and procedures in place, and manages those, first off, that you have the tools that you need to be able to keep yourself trained or have the proper disposables to do that type of
Yeah.
case, because that's a big loss. You don't do these cases very often, so most of the time that stuff's going to expire.
They're gonna
on the
get
shelf.
tossed.
Yeah.
Yep.
But I mean, that's if you want to have a heart program, that's what you do.
That's the
need
cost.
So I think those are the two people that are responsible. You know,
Well, let me throw this at you, and I want to hear your elaboration. But I brought this up to Christine earlier today, and you just said something that triggered it. You remember Don Rumsfeld, right? And I can't believe two times in a row in one day I get to quote him. There's things we know we know. There's things we know we don't know.
There's
Right. There's the things we don't even know we don't know. And so I found it interesting that you put that responsibility not only on the clinician, but somebody else like an administrator. How in the heck are they going to know that?
Well, it's their job. Here's my point. It's not their job to know the procedures. It's their job to make sure that training is available and that there's safety protocols in place, and that's a safety protocol. So if you're an administrator, you don't know anything about perfusion, hey, you've never even been in cardiac surgery, but now this is your job.
Ask the questions, in other
Ask
words.
the questions.
And say, what do we need to do?
How do we set this program up? How do we make it safe? Meet with the surgeons and say, what are all the possibilities of things that could go wrong in your operating room? Tell me what you'd be concerned about. Well, I'd be concerned we got a dissection. We never do those here, or we had to put someone on ECMO. We have the machine, but we haven't done one in 5 years.
Oh, they probably have a heart-lung machine to put them on ECMO.
Yeah,
They don't
or
really have a
whatever.
machine.
But the point is that you have to, I think there's a responsibility as an employer to seek out the information so that you can make sure you're providing the resources to the employees to be safe.
That's a really good point. For those administrators out there, I hope you were listening to that, because this lives in infamy. This lives in perpetuity. This is on YouTube forever.
Yes.
And I think that's a very good key opinion.
Yeah.
That
No,
I
they
think
don't need to know
be-
everything about the
Right,
profession.
they need to know to ask.
Right.
And they should be asking if they're going to be the administrator. I think it's a very good point. That's a good lesson.
Right. I
Okay.
think so too.
So, of all the things you can think of from a perfusionist perspective, you can pick, I'll let you pick 3. Give me 3 words. If you were in a position right now to hire somebody, what are the 3 attributes you would want your prospective colleague, employee to have?
Should we each do one and round table it, or he's got to do all 3, then I'm doing 3 and you're doing 3?
I'm not going to do any. I get to ask the questions. I'm the moderator. What are you talking about?
Oh, I would think realistic.
So, realistic. Okay, let's put that down.
Are we expanding on this, or just,
Yeah, I'm just going to get the words first.
okay.
Start with that.
Willingness.
Willingness, okay.
Determination.
Determination, those are good ones. I like all of those. Tammy?
Flexible. Adaptable.
Flexible.
However
Okay.
you want to say that.
Okay, I'll just put adaptable. Adaptable. Okay, because I'm adaptable but very inflexible now in my older age. But go ahead.
Okay. Well, my point is you can't be rigid in your ideas.
Yes.
This is a very fluid profession, and you have to be willing to bend. Well, I think this one has, the next characteristic I think is important, has kind of a double-edged meaning, because you need to be one way completely and the complete opposite way at the same time. You need to have the ability to work with others, but you also need to be very self-sufficient. And I think that has to do with, in the beginning, of course, you're not
So
going
an independent, let me see if I can say it the way I want to say it. So would you agree you were trying to say an independent team player?
Sure, that sounds great.
Okay. And you need one more. Anybody else want to call in and tell us one? We got the phone lines open, but nobody wants to call. We got people watching though.
Yeah.
Chat it in. Do something.
I think a willingness to learn. Did you say that?
He just said willingness.
Okay.
Willingness.
Well, I think,
Willingness
That's a
to
catch-all for a
learn.
lot of willingness to do.
Willingness.
to
That's
learn,
okay.
to
There
do
could
a
be
lot of different
crossover.
things.
Yeah.
To learn. You're just being a little more narrow, focused, and specific. Okay. So I'm going to try to come up with 3 as well.
Okay.
So I had written one down earlier. So this is Tammy. So I'm going to put curious. I'm going to put, you already said adaptable. Curious. I'm going to put,
oh, I thought of a good one.
tell me.
You have to be willing to communicate. Our job requires
Good communicator, okay.
communication.
So I'm going to give you that one. Good. So I'm going to take the willingness, because he had willingness. Good communication skills.
And if you're not good at communicating, learn to communicate. That's a
You have
big,
to.
That's a big part of our profession.
It's huge. So I'm going to have curious. I'm going to have innovative. And I'm going to have durable.
Oh, that's an excellent one. Do you feel durable?
Durable. Not me, not much anymore. So these are Joe's. Okay. So let's talk very quickly. What do they need to be realistic about, Mike?
I think you need to be realistic about what you are able to accomplish. I think if there is a chance to grow new technology, you do it. I think there's also a situation of, which kind of falls in the adaptability, kind of a sisterhood here, is that you have to realize you want to get there, but you have to be realistic in taking the proper measures to get there. You don't go there from A to Z when you know that L and NOP need to be done first.
When you say get there, what does getting there mean?
To the end point of where you want to be. It's
you're talking about professional growth, development, salary, position.
I'm talking more about patient care.
Okay.
And what you can get accomplished in there. I think if your program is, we mentioned earlier about only doing cabs and those things, that's okay, but you still gotta push other techniques and other therapies, things that'll help patients. So
you're saying to be able to add treatments, in other words, go in there and learn about some new technology, TCD, transcranial Doppler. I talk about that all the time. Add it into your service line and take ownership of it, so that you may be a pain in the neck with everybody in terms of getting in their way, but you're doing the work to do something to bring value to the patient care in the institution that you're affiliated with.
Right. Realistic, and the last part about the realistic part about is that if it goes back to education, if you don't really know how to do it, talk to somebody who's done it before.
Get a mentor.
Get a mentor.
Exactly.
Look at, there's how many articles on how to do things. You know, learn it. You know, maybe maybe it won't be perfect, but if you've got the knowledge base to go, I've got to get from point A to point B, and how can I do that? If I do that, and then I can go on to point C and right on down the line.
And I would recommend too, see if you agree with me, because I've done it. I've done it as a seasoned perfusionist. Called somebody up and said, "This is what I'm confronted with. Do you have any experience with this?
Do you have any suggestions?
Tell me what you did. Tell me what I need to watch out for." So I would recommend, I don't know if you agree, to our younger colleagues, reach out to an older, more seasoned, experienced perfusionist that you value their knowledge, and don't be afraid to ask for help.
Right.
Well, and the same goes for the seasoned perfusionist. You have a new perfusionist in your community on your team. Respect them as a colleague, but also offer, your wisdom.
Yes, if they will accept it.
If they will accept it has to be from both sides.
Because there's a lot of people out there that come out of school and think they know everything, and they don't want to hear from the old timer.
Well,
we didn't do it that way in school.
But and the old timer too, though, thinks that the new person coming in is
dumb as a box of rocks.
Yes. So we have to work together.
Agreed. Okay, so I'm going to let you pick one of your three. You had adaptable, independent team player, good communicator. Which of those three do you want to expand on?
Adaptable.
Okay.
I honestly think it's the most important quality for a perfusionist, just because your situation, whether it be what's going on in your case, what kind of job you're going to be, doing it, institution, non-institution. You might be at the same job your entire career, but it could change. Your responsibilities and how, your day-to-day work could change and is likely going to change. And so you need to be adaptable if you want to have job satisfaction, and you also want to be able to be successful in this.
And respected by your peers.
Right.
Yeah. Adaptability breeds longevity.
In the hospital. Agreed with you. Now, I kind of cheated you. I picked realistic for you.
Okay.
Is there a different one of these three, willingness and determination, that you'd rather expand on? Because I kind of gypped you, and I don't mind. Which one do you want to do?
I think the little bit there, that determination is right in line, hand in hand with commitment. I think I got into the profession knowing I was going to be in it probably for the rest of my life because I was tired of school, But I knew that I had so much more to learn. So I was determined to learn everything, determined to keep abreast of the new techniques, to keep going to when you've done those 48 hours of practically working 36 of those 48 hours, that you know that you're going to, if somebody calls you again, you've got what it takes to get up and out of your bed and go do it again. And so I think the determination is a huge part of it. I mean, it's so easy to quit because it gets too hard, or you can't handle it, or whatever the case may be. Just keep going, because you're not the most important person in this equation. I think we lose sight of that. That
Very
fact.
good point.
And we owe it to the people that we help protect to be this way, to have the discipline, to be ready at a moment's notice. I always think of ourselves as the Minutemen of healthcare, because all of a sudden, and a phone call comes at 2:30 in the morning, you're expected to be on your game, while a lot of other people maybe have seen that patient for the last 6 or 8 hours and know what's going on. You walk into it and you have to assimilate everything real fast.
Yes.
That's
right. And
So-
it could be also a disaster that your colleague got into, and you're in
Right.
there to help them, and you have no clue what has been going on for the past 2 hours, 4 hours, 6 hours, 8 hours, even 12 hours, and you're there to help.
Yeah.
And you've got to be, you have to be on top of your game. I want to say this, and if you could go to a wide shot of this for us, if you don't mind. I want to say this before I get to mine, because this applies to both you, Mike, and you, Tammy. And this is for all of the younger people out there. I want you to hear this, okay? And I want you to remember this. I know all of the surgeons that you and you work with currently, and many of them that you worked with in your pasts. And I can say with absolute 100% certainty, and I know it factually, that any time you two walked into the room when they had a case, a difficult case, a problematic case, a situation going on, there was a sigh of relief that you were there. And that is what the pinnacle of our job and profession is. When you get that kind of respect and you have that kind of an influence on somebody who is happy to see you come through the door, not because you're the monkey behind the pump, but because you are the monkey behind the pump. You're the one.
Specific monkey?
The specific monkey. You're Monkey Mike and Monkey Tammy. Okay? It used to be like that for me. It's not so much anymore, but whatever. It used to be. Okay, I used to be. And I took a lot of pride in that. Because to me, that you cannot have a higher compliment than that. And I know that's true for both of you. In fact, it's true for a lot. It's true for actually our entire team. But you two in particular, you personify what this profession is supposed to be. It's a profession. You've said it several times. You've said it several times. This is not a job. If you want a job, Walmart's hiring.
There's lots of other things to do out there.
You could go to the tire place that fixes your tire for free. Forgot the name of it now. What's the name of that tire
Discount
company?
Tire?
Discount Tire. They're hiring. I know that. There's a lot of different things you can do to have a job. This is a profession. These are real lives at stake. And we have tremendous influence on the outcomes of these patients. Tremendous.
And tremendous responsibility. That's why we have to do these things.
That comes with it, yes.
Right.
So my, and I have three. I have curious, innovative, and durable. And I got to pick one.
God, I hope you pick durable. I want to hear this.
I'm gonna. You can expand on durability. Durability is important, but I'm gonna pick curious.
Okay.
Curiosity to me is, I know for you, determination is
Me?
Yeah, yours was good communication. No,
No,
yours
it was
adaptability.
adaptable.
Adaptability was the most important thing for you of your three. Which is the most important? Realistic willingness or determination?
I'd say determination.
Determination is your most important one. For me, it's curiosity. Curiosity to me is the number one most important attribute that any healthcare professional can have. That's my view. I think you need to be curious. Yeah, I think you need to always be asking why. Why. There, you cannot ask why enough times. You can't ask why about too many things. If there's a stroke rate of 3% for this procedure, why is that okay? It seems good. Man, that's really a low stroke rate, unless you're one of the 3%.
Right.
It's no longer a good stroke rate. Why is the renal failure rate what it is? How am I possibly contributing to this? How can I contribute to it being better?
Right.
Well, and it's not just what's exactly within what you're doing specifically.
Correct.
You could expand that on, an easy topic I think everybody can relate to, blood conservation. You can be a big part of that, but not just in what you do. You can be a part of promoting that. Oh, no, anesthesia, we're probably okay. Why don't we just ride this out a minute? Let's see if this, little things like that. You can have a huge impact if you're doing that every day. Your colleagues are doing that every day. Next thing you know, you've got great transfusion rates.
Right.
They're low, so it's not always just specifically what's in your,
Domain. Using a military term, we're the best first officers. That's what we're supposed to be. I know anesthesiologists technically outrank us, and I like most anesthesiologists, most of them. That's like people. I like most people. I don't like everybody. Everyone loves me, however, you know that to be a fact. But I think that we really are the eyes of everyone in the room. We see everything. We hear everything. We're always kind of looking and going, what's happening right there with that. But we have to do it in such a political, sensitive way. You can't be bombastic.
No.
You can't go yelling at people. What are you doing?
Well,
It has to be more subtle, more professional,
especially
justification for it.
New colleagues, you also need to build a bit of a relationship up with when you get your job at these places or you switch jobs, so that people trust you and start to trust your knowledge.
Yes.
You come in, this is the way we did it, this is how I'm going to do it, and you're inflexible, then you're going to put up barriers that don't need to be there. Because you're going to run into some people who are never going to listen to you no matter what. They're not.
Yes.
But if you, I think you'll find most people, especially in the climate that is in, the operating rooms today, is collaborative. And if they think you have something of value to share, they're interested.
Agreed.
Yeah.
Agreed. Okay. So I think believe it or not, we've done our second 45 minutes. Our time has run short. If you would be so kind as, David, if you don't mind, can you put up our Saturday program? I want to talk about our Saturday program just for a second. Yes. Our Saturday, our second part of PerfWeb 32, as you can see there, we have Dr. Joy Thula, who is a pulmonologist who specializes in lung transplants. And he is also a vaping and lung injury expert. He's going to be talking to us about that, vaping and lung injury. We're going to have a social worker who's also involved in education, Tracy Howarth, going to be talking about the prevalence of vaping in schools. And her and Michelle Brodowski, who's also an educator, has been sending me videos of these various kids who are getting lung transplants from vaping associated lung injury. I mean, where their lungs have been they're getting transplants. Their lungs are gone, they're trashed. So that's going to be very interesting. Then we're also going to be talking about VV ECMO and cannulation strategies and anticoagulation. We're going to be talking about the ARDSNet review. We're going to be doing an ARDSNet review on the optimal vent settings for VV ECMO, and I'm going to be talking about the ELSA meter. One of the things that in our practice, in our regular practice that we do, is that we don't check the cannulation position and maximize therapeutic efficiency. So even though we end up putting the patient on ECMO, usually we've been beating them with the lungs, we've had high pressures, we're 100% FiO2, we're struggling along, the patient's satting 76, 78% arterially, we put them on VV ECMO with a single cannula in the right atrium or dual cannula technique, whichever technique you want to use. And there's a variety. I'm going to go over those as well. But the SAT suddenly comes up and gets to 100%, and we're so happy because now we have solved the problem. However, we haven't turned the vent down yet. Now comes the struggle. We get to the unit, everybody's happy, and we want to start bringing the vent down. And all of a sudden, we can't really get it down that far, and we really can't rest the lungs the way we should be wanting to rest these lungs, because when we do, the SATs are falling below 89%. There's generally going to be a reason for that. It could be a variety of things, certainly, but it can be, and probably more likely than not, too much recirculation. And we can infer it from a whole bunch of different methodologies. We can measure the venous coming from the line, and we can measure the SpO2 from some other vein. We can do a lot of things. We can see our return access line mixed venous going up, and sort of infer from that we're probably recirculating, but we have no idea how much. Yeah, if it's 100%, obviously we would know it's 100%, but you know, or a lot. But if we had a tool that exists that frankly is not that expensive, made by Transonic, I'm going to be talking about it, called the ELSA meter. You can give a single bolus in an adult. You can do it in children too, but it's a different quantity. You give a single bolus of 20 cc's of saline, and it gives you two calculations. For VV ECMO, two calculations simultaneously. It gives you oxygenator volume, so that if the brochure says the volume is 220 cc's, and it's a brand new oxygenator, it should still be 220 cc's unless you gave patient no anticoagulation, you pumped a bunch of clot into it. But there's not going to be any clot in it if you anticoagulate it at that point in time. So it gives you a baseline of that. The second thing it does is it gives you the percentage. It gives you a quantifiable number, the percentage of recirculation. You want to be about 15%. But if you're right there, you just put the cannula in, you're on ECMO, it went up to 100%, everybody's cheering and excited, and you go and shoot that, and it's 45 or 50%, guess what?
Got a cannulation problem.
Exactly, and you're not going to be able to rest those lungs the way you want to and maximize the opportunity for that patient to recover, or the recovery is going to be delayed secondary to the ventilator associated barotrauma and other things.
You're only on half ECMO.
You're only on half ECMO, exactly.
You're on like a baby oxygen.
You're on V ECMO.
Yeah, you're V ECMO.
And turning this flow up, I can show you on graphs, turning the flow up makes it worse.
Yeah.
So I really think this needs to be a standard of care, because you're right there, and you can say, hold on a second, Doc, our recirculation is 38%. I can check another one to be sure, validate it if you want, but I think we need to move the cannula. You make a little adjustment, you check it again, you get it down to 20%. Now you got to make a decision. 15% is probably perfect.
Yeah.
20% you probably can do okay with. I'd probably be okay. 24%, maybe even 25%. I might still be okay with it depending on the patient. But if it's 38%, 48%, 52%, we should not secure that cannula in place until we've fixed it.
So
and that's going to improve outcomes. That's what I believe.
This is a part of the initiation process, is what you're suggesting. That you're,
Yes.
you're checking that before anybody's even leaving.
Before they
bedside
secure
or whatever.
that cannula with us, before they say it's where it needs to be. It might need to just come back. I mean, when you look, I'm going to show you on radiograph how those cannulas, those inflow and outflows, they're so close, especially to the SVC. You know, as the IVC, you know you got it dipped in there. But are you in too far, and that inflow is really in the superior aspect beneath, essentially inferior to the SVC RA junction, and you're really sucking all of your treatment blood right back into it, or a large percentage of it. So more than likely, if you have a lot of recirculation, it's going to be you're too deep, not too shallow. Because you can see the tip, and you can see the IVC, and you can see where the right atrium is. You know you're in the IVC, but it just might need to come back a little bit to be for that proximal port to be sure it's in the superior vena cava and not in the right atrium. So, with that said, the program Saturday is going to be top notch. We're going to have a studio audience. There's going to be a lot going on, so I highly recommend you tune in. And we're over time, so the board won't give us any extra credit, so we're fixing to go lights out. I'll see y'all on Saturday.
The point of care program at Huntsville Hospital is approaching its 20-year anniversary. As we began to grow as a hospital and provide more complex services to our community, the need for point of care testing became very clear in our organization. Many of our departments consider the EPOC device to be crucial to their ability to quickly move their patients from entry to the hospital to procedural room. It helps them monitor the patient's status during their procedures and post-procedure, so it's very integrated into our entire continuum of patient care. If you have any patient population where blood management is crucial, then a point of care device is very useful in those types of settings. It can provide a quick result on a very small amount of blood, and that is really important in some of our patient population.
We are starting a new process where we're going to screen our patients on the floor for sepsis. The patient can look and actually feel okay. They will show us signs and symptoms of sepsis. So what we do when they show these signs, we get a lactate level.
Lactic acid is a product of the sepsis cascade. So with sepsis, the inflammatory light switch goes on, the cascade starts churning, and unfortunately, once it starts going, we have to stop it. It will not stop on its own. The faster the lab draw, the faster the lab results, the faster you can act on it.
The process in the lab is what the process is. It just takes a certain amount of time for the instruments to run those tests.
I mean, we're talking 30 minutes even on a stat, because that's the process. That's just how long it takes. There's not really anything you can do about that. For every hour you wait to give an antibiotic, the mortality for that patient increases 8%. So now that we have the handheld device, the nurse can get those results within a few minutes, and we know how to treat that patient. If a patient is going into septic shock, we do not have minutes to spare. We have got to get it done quickly. So when you get the little beep from the EPOC that says your results are in, you go with it. You don't even think twice about it. You're like, this is good. This is what I'm going to do for this patient. The next steps are clear.
I think our mortality on the initial floors dropped by almost 50% in the first 3 to 6 months. At this point, we're about hospital-wide. I think we'll be hospital-wide another 2 to 4 months. So this has become a huge program within our system.
Without the EPOC device, it would really be hard for us to get everything done in the timely manner. So it's really helped us to get our program going.
I mean, whether you're a surgeon, whether you're a medicine doctor, whether you're a dermatologist, you want to be able to do things in a timely fashion so that you can be most effective.
This really makes a difference in patient outcomes.
Mixed cannulae, expanding performance standards. High-performance cannulae for direct and femoral cannulation in minimally invasive cardiac surgery. LivaNova's complete range of mixed dedicated products allow easy and reproducible procedures. The portfolio includes the sutureless aortic valve Perfusion, Memo 4D for mitral valve repair, the HeartLink system for assisting the perfusionist in applying goal-directed perfusion therapy, and a broad choice of high-performance dedicated cannulae. LivaNova's range of cannulae suit every cannulation technique for minimally invasive cardiac surgery. Venous and arterial femoral cannulation can be performed using the WRAP venous cannula and the EasyFlow Duo. For arterial direct and venous femoral cannulation, the EasyFlow aortic cannula and the WRAP are available. For venous femoral access, the LivaNova WRAP cannula features a dual-stage configuration for optimal drainage of the inferior and superior vena cava without interfering with the right atrium. The high-flow dynamics of WRAP improves the capability of drainage with a low pressure drop. An optional Sellinger dilator kit is available to perform percutaneous insertion. The LivaNova EasyFlow Duo cannula is designed for a safe and smooth femoral arterial cannulation. Its conical dispersion tip design allows a more gentle flow in the femoral artery, and its red cap avoids blood backflow during obturator removal. A dilator kit for percutaneous insertion is also included with the cannula. EasyFlow cannulae are designed for safe, reproducible, direct aortic cannulation and include a malleable stylet to aid cannulation insertion, facilitating bloodless introduction into the aortic arch, as well as a special conical dispersion tip for a more gentle flow in the vessel to reduce shear stress.
Like all perfusion professionals today, we are busy and frequently short-staffed. Does taking time off for a conference create a burden for your teammates? Has reimbursement for your continuing education dropped? Have you priced the cost of going to a meeting lately? Registration fees, airfare, transportation and parking, hotel, and meals out? This totals up to having an out-of-pocket expense of over $2,500. And then you hope the content is good. Perfusion Education has heard your concerns. They have a simple and seamless system that works on any platform, computer, tablet, or even your phone. You can chat during the program or even phone in and be live on the air. The content, second to none. Perfusion Education is by perfusionists and for perfusionists. Create a free account and check us out today.